So we talked about all the different diseases and key features, symptoms and signs whenever patients have dyspnea and they present with additional symptoms and signs, and how do we approach them. Now to recapture all of it, just a few more slides to go through. So this is how we approach a patient who has dyspnea, and we already talked about it in the very beginning, but I'll review it again here. So if a patient is stable, if the patient is not stable, and you can see they can't even talk, they can't finish a sentence, they have pretty alarming vital signs, tachypnea, tachycardia, hypoxia. They have a stridor, which is a key feature of upper airway obstruction, or if they're using any accessory muscles of respiration or drooling, then obviously you're going to say, okay, these are red flags and I'm going to go ahead and intervene, and this is how you intervene. Of course, at the same time, you're going to start thinking immediately about all those diagnoses that can cause all of this. So it can be either anaphylaxis or angioedema in the case of stridor. It can be a flail chest, a trauma patient can show up like this, or it can be an acute exacerbation of asthma, in which case you don't see stridor and you don't see drooling, but you see the rest of the symptoms. It can also be a toxic or a drug overdose injury or neurological disorder, for example acute Guillain-Barré syndrome progressing to the muscle of respiration. So that's what you're going to keep in mind, these diagnoses, and this is the symptoms. But if your patient is stable and you can say, all right, none of these is present, or very mild degree of abnormality in vital signs is present, then you're going to say, all right, I'm going to start with the history, in the history the most important question is duration and onset. So duration is very important to ask, but it doesn't mean you don't ask about duration and the rest of the questions in a patient who has red flag situations. You will ask this question in those patients too, but it will just come later on, or it will be at the same time when you are doing the management sort of. So we went through this already, but let's just move on to the next slide. So this is again a quick slide to show specifically what to do when you have, and what findings to look at when you have a patient with these different disorders or pathologies. So if it is anaphylaxis or angioedema, swelling of the upper airway is usually present. There is perioral tingling or history of exposure. If it's a trauma patient, then you will see the history, or you will hear about the history of trauma. There is a rib fracture. If a patient who failed asthma treatment, so they had asthma already, and then either they ran out of the inhalers or they just failed the treatment because there was some exacerbating factor, then you'll see this scenario. If the patient has on top of the symptoms that we just described, if they have now choking or red pill infections, they might have aspirated something. So that's how they can present with upper airway obstruction, and they will also have stridor. And patients who just recently got overdosed on something or have an obvious a toxic exposure or ascending paralysis, then you will think about this diagnosis or disorder. So this is just another quick overview, and of course in inpatient setting, the patient may just develop a very florid pulmonary edema and become acutely dyspneic with red flag situations. And here you're not probably gonna like it very much, but I'll just quickly talk about what do we do. So patients with upper airway swelling or angioedema, steroids, and you can intubate. Patient with rib fracture, supportive treatment or surgery. And patients with history with failed asthma treatment, we can use steroids and bronchodilators. We already talked about it. We can also intubate if we need to, so there is criteria for it. Patients with infections or aspiration or choking, then we're going to remove that offending agent and give antibiotics. We may need to intubate too if the patient is too ill or critical. If patients with obvious overdose or ascending paralysis, of course we will either give antidote to the poison or toxin, and also give supportive treatment in the form of intubation. Alright, so that part is over. Now let's quickly talk about the key features that are differentiating among broad categories. So so this slide basically shows how it is very important to ask about chest pain whenever somebody has shortness of breath. So after asking about duration and onset, the next good question, logically speaking, would be chest pain. So whenever the chest pain is present, you can start thinking, okay, it could be any of these things. So it could be an MI, pneumothorax, aortic dissection, or pulmonary embolism. So see, there are two cardiac and 2 pulmonary, but pulmonary embolism can be considered both cardiac and pulmonary cause, but anyway there are 2 P's and 2 cardiac causes. So these 4 things are absolutely important to keep in mind whenever patient has dyspnea with chest pain. And of course you will ask further questions about chest pain, and each chest pain is going to be characteristically different from each other, so that's how you will get to the diagnosis. So this is how it becomes very easy to sort out and solve this very complex problem of dyspnea. And you will ask additional symptoms about each diagnosis and look for risk factors. So this is basically your blueprint to approach or evaluate a dyspnea with chest pain. If it's substernal or radiating to the left, nausea, diaphoresis is accompanying the chest pain, then MI in the presence of risk factors. Patient has a sharp chest pain and it was very severe at the onset and then got better, then it's probably pneumothorax. Patient had very sharp tearing chest pain radiating to the back and has very acute hyperacute condition with some accompanying hypertension or hemodynamic instability, then it's probably aortic dissection. Patient who has pleuritic chest pain, so more chest pain with taking deep breaths in, and has some immobilization and risk factors that we talked about, there are multiple, and maybe has some leg pain too, then we will think about PE. Now if there is no chest pain, then of course all other causes are possible. So again, it doesn't mean that it's a very complex or complicated situation, we cannot solve it. We have more tips to solve this situation. So when there is no chest pain, there is only shortness of breath, the next good question would be if they have any cough or phlegm, and if they do, along with fever or wheezing, then this set of whenever these group of symptoms is present, maybe 1 or 2 or 3 of them present, then this group of problems can become more obvious. Then okay, this patient maybe has pneumonia or bronchitis or COPD exacerbation. So this is how you can link these high yield questions and answers to these questions to these diagnoses. And of course you're going to auscultate the patient and look for physical exam findings and do the chest x-ray too. If a patient has just wheezing, only wheezing, and none of the other above things, so there's no phlegm, maybe there is very dry cough but there's no fever, there's only wheezing, no history of asthma, then you must definitely think about still cardiac causes, because there are some patients who present with something called cardiac asthma. So what they have is just wheezing with dry cough, and what they really have is left ventricular failure. So this can be an odd presentation, so just keep this odd factor in mind. So you will of course do the rest of the exam, and you may find out that they have edema or jugular venous distension. So that's how you can differentiate. Patients who along with the shortness of breath, even if they don't have any chest pain, but now you know that they have orthopnea and PND. So remember we talked about left ventricular failure, or even pulmonary hypertension patients can present with orthopnea. So that's how we will cue into this diagnosis. And so whenever you find this shortness of breath with orthopnea or lower extremity swelling, you will look for risk factors, and if any of those are present, this is just an example, but of course there are more risk factors, then definitely start thinking about left ventricular failure and do the physical exam accordingly. Also, lower extremity swelling doesn't have to be cardiac. It can be non-cardiac. So in the presence of shortness of breath with lower extremity swelling, there are some other things too that can cause it. So heart failure is the number one, but chronic renal failure can also cause lower extremity swelling and shortness of breath, because remember this is another fluid overload condition. It will lead to these symptoms. Cirrhosis of the liver eventually, after causing splenomegaly, ascites, and fluid overload, will cause lower extremity swelling and shortness of breath. By this time they have advanced so much that it is quite obvious usually to diagnose these patients, but regardless you must know the symptoms and signs. So whenever you're suspecting heart failure, we already went through all of this. So BNP, metabolic panel, and CBC will need to be done. For the rest of for renal failure and cirrhosis patients, metabolic panel usually will give us everything that we need in terms of whether it is renal or hepatic, because you will get the hepatic enzymes and creatinine. Again, patients who you are suspecting as heart failure, they will present in the setting of some risk factors that are already present. So you will draw BNP whenever you are suspecting heart failure, because you got these two findings and you got some risk factors. Again, if you have shortness of breath alone, but there is no chest pain, there's no cough fever, none of these present, and your next question is palpitations, and if the patient says that yeah, they do have palpitations, you can think about anxiety, because that is one, but this is usually a diagnosis of exclusion, so you must think about anemia, atrial fibrillation and arrhythmia first, because AFib is going to present with palpitations whenever they have shortness of breath. SVT will do the same thing, and of course you will auscultate the patient, and sure enough the heart rate is irregular and EKG will give the final answer. On top of all of this, if the patient has pallor, so you have started to look at the patient already and they show that there is some pallor and their hemoglobin is less than 7 or 8, then you definitely look for other causes. If their hemoglobin is more than 7 or 8, then look for other causes, because then this means that their dyspnea is not necessarily because of anemia. So don't blame anemia for dyspnea if hemoglobin is like 9 or 10 or 11, because they don't usually get shortness of breath so so easily. So whenever you see pallor, check for anemia. Of course, do the CBC, look for acute and chronic causes of blood loss or dietary deficiency. So we talked about all of that, and the test would be hemoglobin. So this is how you can go down the list of your questionnaire. The next would be, if your patient has none of these things present, or maybe has some of these things, but now you also know they have uncontrolled diabetes and the dyspnea is very acute, and they are not only sick with dyspnea, but they also have maybe some altered mental status, maybe they have all the symptoms and signs of metabolic acidosis, then you definitely think about DKA and you check blood sugar and ABGs. If your patient, this is an unusual scenario, if the patient doesn't have any of these things present and just has dyspnea with drowsiness and maybe even headache, then we are going to think about toxins and exposure or drug overdose. If your patient already has paralysis and you know that they are paralyzed and now they are developing shortness of breath, then you already know what to do. You either look for GBS or stroke. So this will be fairly easy to get to, because the rest of the symptoms will be so obvious. Another thing was altitude. So high altitude, there will be very clear history. Patient will say they just walked up a mountain and that's how they got short of breath. So again, like I said, these last three things are not as common, or at least not as common presentations where people come in with chief complaint of dyspnea. Their chief complaints are usually different, and dyspnea is an accompanying symptom. So that's why you just keep that in mind. So you can see that after we've reviewed everything and we've captured all of the material, dyspnea, duration, onset, chest pain, and then these symptoms become the very high yield questions. So whenever you ask all of these symptoms systematically, chances are 90% of the time you'll be in the ballpark of a diagnosis or a correct diagnosis. So remember to ask these symptoms very carefully. And this is, I think, the last slide. So the slide before the last slide. You may not like me for this because this is another review or capture of everything that we just did, but mostly it's focused on pulmonary versus cardiac causes of dyspnea. So we know that pulmonary and cardiac causes can be very, very overlapping, and there's a lot of mixture of symptoms and signs. So how do we identify whether it is pulmonary or cardiac? Well, there are some subtle features. So patients with pulmonary causes of dyspnea, usually after asking about duration and constancy, you ask them if their dyspnea is worse after when they lay down, or it's about the same. If they say it's about the same, then maybe it is not cardiac. And then the rest of the features would be they may have wheezing, they may have cough and phlegm and pleuritic chest pain. So although the chest pain is present, but it is usually pleuritic because now the pleura is involved, and that's how you know that it is probably pulmonary. On the other hand, and also in addition to that, so when you have these findings present and you've basically based upon your logical reasoning, you have asked these questions and you have said, okay, well, all of these are pointing toward pulmonary causes, then you'll look for pulmonary pathologies. So basically asthma, COPD, bronchitis, and pneumothorax, and that's how you'll say, okay, although my patient has chest pain, but it is very pleuritic and the rest of the symptoms are present, and the dyspnea is not getting worse when they're laying down, then maybe this is a pulmonary cause of dyspnea. And usually they don't have any lower extremity edema. On the other hand, if it is a cardiac cause of dyspnea, then the high yield features would be they usually have a cardiac chest pain or non-pleuritic chest pain. They may have palpitations if it's because of arrhythmia or AFib, and very importantly, they have lower extremity swelling. So usually whenever the fluid starts to accumulate in the lungs in the form of pulmonary edema and cause dyspnea, and it's worse when they are laying down, they also have fluid accumulating in the lower extremities in the form of pitting edema. So that's how you know this is cardiac, and eventually they can develop abdominal swelling, but this is usually a late symptom. So whenever these features are present, you ask about chest pain itself, and you know that okay, this is typical cardiac chest pain, or maybe it is not cardiac, maybe in this case it is pleuritic, but because other risk factors are present, that's why I'm going to think it is PE. And if there are other symptoms of fluid overload, then you think about heart failure. If the patient is very sick with hypertension, then either it's one of those cardiac post-MI complications, or it is aortic dissection. So definitely keep this in mind. So this is how pulmonary versus cardiac causes of dyspnea can be differentiated based upon some very key questions, this one being the first good question, and then there are other questions. So next, this is the last slide, so I hope that this will just kind of end, put everything together. So this again, we already looked at it. So after we've done ABC, we made sure that patient has a proper airway, breathing is restored, and circulation is maintained. You obviously look at red flags. So these are the red flags that we already talked about, and whenever these are present, you're going to start looking for these diagnoses. And if you have throat pain and dysphagia, then maybe there is an infection. If there is obvious foreign body, then you know it. If there is swelling, then there is edema and anaphylaxis reaction. But if there is a history of trauma, then maybe it is a flail chest or pneumothorax. So that's how you basically identify these key features linking to the specific diagnosis. On the other hand, if there is no red flag symptom present, then it still could be acute causes of dyspnea. So the first good questions would be duration and onset, and it could also be chronic. So next few questions would be chest pain, wheezing, palpitations, cough, fever, and phlegm. If dyspnea is worse when they are supine, or if they have any swelling or history of diabetes, pallor, weight loss, or headache, and if they are in ICU setting. So these are going to be your basically, if you want to summarize all the questions, these would be your summary of questions, and maybe some more, of course. Oh, okay. All right. So, and then there's going to be obvious causes of dyspnea. And these two tables we already looked at in the beginning, so just review it again. So this is basically the end of discussion on shortness of breath. I hope this was helpful, and I hope this put things in perspective. So this is how we approach a patient, this is how we look at different diseases and figure out what are good important key questions that can help us arrive at the diagnosis logically, efficiently, and accurately. So if you have any questions, feel free to email me. I'll be happy to talk to you about it. Thank you so much.